Hello, everyone. Welcome to LAIVF's webinar series hosted by Dr. Akut Bayrak and co-hosted by myself, Ara Behagan. Today, we will be discussing carrier screening versus pre-genetic testing. Before we dive in, I want to let you know that everyone who has joined this seminar will receive a free 30-minute consultation with Dr. Bayrak, either in person or via Skype. And I'll give you the details at the end of this webinar, so hang tight. So without further ado, let's dive into our topic at hand. Dr. Bayrak, I was hoping we can start with the definitions of carrier screening and pre-genetic testing.
Yes, of course. So carrier screening refers to testing for a number of diseases that somebody may be carrying, but not have the actual disease itself. And there are probably thousands of diseases that one can get screened for. It's fine to be a carrier of a disease. We probably all carry some kind of a gene disorder or some kind of gene mutation. The ones that are being tested are the relevant ones, at least today. The screening does allow us to identify those individuals who are carriers of a gene disorder. What that means is that person doesn't have the disease, but if she conceives a pregnancy and has a child with a partner who's the carrier of the same disease, then there's a risk, there's a chance that that baby may not only be a carrier, but may also be affected, where that child may actually have the disease itself. Mm-hmm. So carrier screening means that if somebody is a carrier of a disease, then the partner has to be tested. If the partner is negative, or if the partner is positive for a completely different type of a disease, then the risk is still not greatly increased. At this time, most of our patients who come in for in vitro fertilization and to have a baby are screened at our clinic for carrier screening. And if one partner is positive, then we typically screen the second partner.
So let me just clarify then, if one partner is a carrier of a particular disease and the other, the second partner is also a carrier, that doesn't necessarily mean 100% the baby will be a carrier, will have the full-blown disease.
That's exactly right. So okay. Let's talk about, for example, one of the most common genetic disorders called cystic fibrosis. So let's say we see a patient coming to LAIVF for in vitro fertilization. We screen her and she is a carrier of cystic fibrosis herself. She doesn't have the disease, obviously, because if she had the disease, we would have already known that, because she would have clinical symptoms and findings and complaints throughout her life, because that's a pretty severe disease in most cases. So without knowing, we would diagnose her with a carrier status. Now, if she's a carrier, then we will automatically offer screening of her partner, and the partner will then be screened. And let's assume for a second that the partner is also a carrier of cystic fibrosis. So if they're both carriers, that means that they have affected sites in their chromosomes or genes, and they have unaffected sites. So if they pass down the gene or the site that is affected with this gene problem, what we call gene mutation, and if they both pass it down to the same embryo, then that embryo has the affected DNA on both sides of the genes or chromosomes, which would then lead to the full-blown disease called cystic fibrosis. In terms of genetic probability, this is typically considered to be 1 in 4. So 1 in 4 babies whose parents are carriers of the same gene disorder will be affected. The true outcome is probably even less than that, because some of these pregnancies can result in an early loss, such as miscarriages. Some of those embryos may not even implant. So the true real-time kind of chance of having a baby with an affected disease or having both of those mutations is actually quite lower than 1 in 4. But genetically speaking, the chances are 1 in 4. Now, what happens to other, 3 out of 4, one may ask. So 1 in 4 can be affected genetically. How about the other 3 and 4? So once again, based on just basic combination or permutation of these genes, there's 1 out of 4 chance that the baby or the embryo will get the unaffected sides, or the unaffected or the healthy or the good genes on the chromosomes. And if that is the case, then the baby will not have the disease, and baby will not even be a carrier, which will be the ideal scenario, obviously.
Right.
So that's again 1 out of 4. And then the other 50%, or the other 2 out of 4, will be carriers just like the parents, because they will be inheriting one side of the chromosome or the gene, where they'll have one side affected but the other side normal, which will not create a disease, but rather render those individuals as carriers, very similar to their parents.
Gotcha. Okay, that's very helpful. So when a couple comes into the clinic and they want to be tested, generally you test one partner first. Is that how it works? And then if they're a carrier for something specific, then the other partner gets tested.
Right, because if one partner is negative, for example, for a whole panel that we typically do, then we typically don't need the other partner to be tested, because even if we test the other partner, and if he or she's a carrier, because the other partner is negative, the risk is not greatly increased. So if one partner is negative, or that person is not a carrier of the genetic diseases, then the other partner does not have to be tested. But sometimes under certain circumstances, we do test both partners at the same time, just to make sure. If they're high risk for any reasons, if they have family history for any reason, maybe they had an affected child in the past with some unusual type of a genetic disorder. So there are obviously exceptions to that rule. But for the most part, it's a common approach to test one partner, and if that person is positive, or carrier, we should say, not positive, because that sounds like that person has a disease, but is a carrier, rather healthy but carrying the gene mutation, then the other partner is typically tested. If the other partner is positive for a different disorder, then that's still kind of normal, regular risk, just like the general population. But if that partner is positive, then we have to counsel them about what to do. And I think that goes into the second part of our discussion today, which is called pre-implantation genetic testing.
Yes. If you could go ahead and please define pre-genetic testing, or PGT, I believe.
Yes. So PGT, pre-implantation genetic testing, refers to testing of embryos through in vitro fertilization treatment for chromosomal or single gene defects. In the past, it used to be called PGD, pre-implantation genetic diagnosis. And then at one point, some practitioners called this test complete chromosome screening. Later on, it was common to call this test PGS, pre-implantation genetic screening. And then most recently, the terminology has been changed to make it clear and to differentiate different types of pre-implantation genetic testing. So currently, we call the whole test pre-implantation genetic testing, just as a kind of an umbrella type of a term and test. And underneath that umbrella, we have different types of PGT. So the most common one that we do is something called PGT-A, PGT-A. That stands for aneuploidy, which means chromosomal issues or numerical chromosomal problems. That is probably the most common PGT that is being done at our clinic and at other fertility clinics as well in the world. That looks at each embryo and determines whether the embryo has cells that contain 46 chromosomes or not. That's really what it looks at, whether the embryo has 46 chromosomes, each one of its cells, along with the X and the Y chromosomes, because they determine the gender, as we know. So it does look at those 46 chromosomes. And when we get the report back, it'll say 45 chromosomes, 48 chromosomes, 49 chromosomes, or 42 chromosomes, or 46 chromosomes. So that test tells us about the chromosome makeup of each embryo. And the common things that we look at are Down syndrome, Turner syndrome, additional chromosomes that may result in miscarriages, or missing chromosomes that can result in early miscarriages, or implantation problems, implantation failures with IVF. The second type of PGT is called PGT-M, and PGT-M stands for, once again, pre-implantation genetic testing. M stands for monogenic disorders, which means diseases that are related to a single gene problem, such as cystic fibrosis. So the PGT-M is tied with the carrier screening, if you think about it. So if somebody is a carrier of a disease like cystic fibrosis, then we test the husband. The husband is cystic fibrosis carrier too. Then we would counsel them about options. One of the options, obviously, is to do IVF, do PGT-M testing, in addition to the PGT-A testing, which can be done from the same sample, from the same DNA. It's just that the DNA and that test type is prepared a little bit differently in advance. So there's a little bit of preparation that is being done in the laboratory before we actually test these DNA samples. But it can be done from the same DNA sample, just from the same IVF cycle, from the same embryos or on the same embryos. And that will then tell us which embryos have the actual disease, meaning both of those genes were inherited that were affected from both parents. Or it'll tell us whether they are carriers or whether the individual is normal and not even carrying the mutation in one of the genes or chromosomes. So the PGT-M can actually identify single gene disorders at the level of the embryo. And with that, we'll be able to put back the healthier embryos, or I should say the ones that do not have the disease, because the ones that have the disease, obviously, those are the ones that we're trying to avoid in transferring into the patient's uterus. So that I think is an important option for these patients. The second option for these patients is to get pregnant on their own and take a chance and take a risk. So when we do that, the patients have to understand that if they get pregnant on their own and the pregnancy does not result in a miscarriage, it continues, they can do testing during pregnancy as early as 12 weeks or as late as 18 to 20 weeks with CVS, which stands for chorionic villus sampling, or amniocentesis. And with those, we'll also be able to identify whether that baby has affected genes on both sides, where the baby will have the disease itself, or one side is affected, or the baby is normal. So we'll be able to determine that during pregnancy. Obviously, that is during the pregnancy. And if the baby is affected, then the patient will be given the option to whether to continue on with the pregnancy, understanding that the baby will be somewhat unhealthy, or they can have the option to terminate that pregnancy. So those are the two options when somebody is a carrier of a disease and the partner is a carrier of the same disease. They can either go natural and do testing during pregnancy, and about approximately 25% or less of the time they will have an affected child where they'll have to make a decision. That may be a difficult decision. Or they can control for everything, test at the level of the embryo with IVF and the PGT testing, and determine everything before pregnancy, before getting pregnant, and then increase the odds of having a healthier child.
And with PreGenetic testing as well, so correct me if I'm wrong, carrier screening has to precede PGT. PGT because
Yeah, that's correct. Yeah, carrier screening has to proceed, right? Because we can't test which gene is abnormal without knowing where the abnormality is, because there are thousands of genes.
So we can't skip the carrier screening.
Right.
We have to do the carrier screening first in order to decipher which genes to look for. And then
that's correct, right.
PGT, then we'll be able to look for those specific gene mutations.
Absolutely right. So without knowing what to look at, there are thousands of genes in the human DNA. One cannot really determine where to look at. We don't even know what's significant and what's not significant. So that would be impossible, or to look at like gene disorders throughout the human DNA. But those patients can still do chromosome testing of the embryos. That is still going to be important. The first one that I mentioned a little bit earlier, called the PGT-A, which looks at the chromosome numbers. So that still can be done regardless of carrier screening. So the carrier screening is not a must. It's not like it has to be done on everybody, but it's a good way to plan for a pregnancy. So especially when somebody comes into our fertility clinic, we are planning that pregnancy, which is a good luxury to have, because almost up to 50% of pregnancies in the United States are unplanned. So they're not planned, which means they see the doctor after they've become pregnant. So they don't really get a chance to get any kind of preconceptional testing done, identification of their risk factors for pregnancy. They probably don't get tested for the carrier screening, right? So most of those pregnancies are unplanned. But when you come to a fertility clinic, that is a planned pregnancy. So when it's planned, as it is in the definition, we can plan for things such as testing for diseases. And if somebody's a carrier of a disease and the husband is a carrier of a disease, then we can plan that pregnancy and minimize the risk, because we now have the technology, we have the tools to select the healthier embryos. So that's, I think, an important concept to understand when somebody's planning on a pregnancy and what their options are.
Right. And in addition to that, this is where gender selection comes in as well, because, so correct me if I'm wrong, if since we're already doing testing on the embryo for, we can also test for gender as well. Okay.
Right. The gender information comes with the report, so it's not typically requested additionally, because they have to also look at the chromosomal abnormalities in the sex chromosomes, the X and the Y, because sometimes you can have two Ys or two X's or XXY. So you can have all these kind of unusual type of abnormalities in the sex chromosome. So it's always a good idea to look at those chromosomes as well. And if there's an abnormality in those chromosomes, then those embryos are typically not transferred either. But that information will be available in the PGT report, whether that embryo is going to result in a boy or a girl. Yeah, that is available in the report.
And we
already.
Sometimes have patients who elect not to know the gender specifically, even so that's an option as well, correct? If they don't want to know.
Right. I think absolutely. I think most
Mhm.
patients would like to just have a healthy baby. They really don't really care about the gender. But it's kind of a nice surprise, I think, to know that. And but beyond that, I think it's good to know that the sex chromosomes are normal too, in addition to the other chromosomes. So that gives, I think, another level of reassurance to the patient. So, but yeah, some patients, they don't want to know. And when we discuss the report with them, we don't even share that information with the patients. And the request typically comes as, let's just transfer the embryo that looks the healthiest, that has the best quality among the ones that are chromosomally normal. So that's typically
Okay.
our
And that brings
approach.
me to another question in regards to, does this, uh, is this testing put the embryos at risk at all? And how does it work as far as, is there a is there a sampling taken from the actual embryo and taken out of the embryo?
Right. So PGT test is done on the embryos. So in order to test the embryo, you need DNA
Okay.
from that embryo, and the DNA is within the cells. So with the current technique, at the final stage called the blast stage, where the embryo has numerous cells, we do an embryo biopsy, which is removal of anywhere from 2 to 5 cells from an embryo that has approximately over 100 cells, let's say. So that doesn't damage the embryo typically. And if it's done carefully with the current techniques, we don't believe it damages the embryo. The issue might be in the case of a low quality embryo. If the embryo is low quality, then by removing, cells, that embryo sometimes may be compromised. Sometimes it's not. It's still a question in our industry, I think, and in the field of embryology, whether to biopsy low quality embryos because they have really few cells. And if you do a biopsy and remove some of those cells, is that good for the embryo? Is that bad? Or does it make no difference at all? Those are still, I think, things that have not been clearly understood. But with the current techniques, the risk to the embryo is considered minimal. But it's still an intervention, obviously, on the embryo. So that means the risk probably is never zero, but it is quite low. The other issue with the embryos is that some of the embryos have different types of cells within the same embryo. Some of the cells are normal, some of the cells are abnormal, which is very confusing. One might say, like, how come there are some eggs that are, some cells are normal? Because they're coming from one cell, right? From one sperm and an egg. But throughout the development, the embryos can form something called mosaicism, where some cells within a certain part of the embryo are normal, some cells within another part of the embryo are abnormal. So if you do the biopsy from the area where the cells are abnormal, but the remainder of the embryo is normal or constitutes normal cells, that's called mosaicism. And there are different percentages. There's 5%, there's 30%, there's 50%. So all depends on the percentage or the level of mosaicism. And this is still a gray zone, I have to admit, in embryology, because we don't really know what the cutoff is, which embryos can be normal, which ones are abnormal. Unfortunately, these are still being investigated. But nevertheless, with the PGT, one, I think, weakness, one disadvantage is when we get a report, that report is really reflecting the cells that we took out from that embryo and might not necessarily reflect the entire embryo, which is confusing to not only patients, other healthcare providers, but also even to doctors and embryologists. So there's a new technology that's coming out where the embryo DNA may be obtained from the culture media. So instead of removing these cells, soon we might be testing the culture media or the fluid, where some of the DNA from the embryo actually somewhat, quote unquote, leak out. And that, based on preliminary evidence, may actually give us a much more accurate picture of the entire embryo and different parts of the embryo. So that's something that may be more and more common, I think, in 2020. So we're also looking into this technology and to make sure that it is reliable technology, first of all, and that it will be at least the same or a better technology or technique than biopsying the embryos. So that's one thing that's going to be coming up. And we actually have a very big seminar coming up in January of 2020, where we're going to be talking about this specific topic that is a very hot topic at that seminar, and present some very interesting medical data and educate healthcare providers as well as the general public, patients. So I would encourage everybody to start signing up for that large seminar, which will be in Los Angeles. And I think that will be announced in the upcoming weeks to sign up, because it's going to be first come, first served basis, and seating is going to be very limited because of these hot topics. And that's going to be related to the topic that exactly we're talking about today, which is PGT. It's just that it's looking like it's going to be non-invasive type of a PGT, which is going to be, I think, it may actually change our field pretty dramatically. But that's going to be coming up, and we'll be talking about more and more of that in the, I think, upcoming webinars and seminars, and with our larger seminar that's coming up early.
Okay, so that information will be on our website very soon, so everyone can sign up there for that large seminar in January. Good.
Absolutely right. If they go to LAIVFclinic.com, they would be able to sign up, or they can call any of the office locations. Any of the 4 locations inside of California would be able to give them further information. But everything will be on the website. I think in the upcoming weeks, there'll be a link, which then they will be able to enter the information and be able to attend.
Great. That was fantastic information. Thank you, Dr. Bayrak. Yes, we talked about carrier screening, pre-genetic testing. That was super helpful. I want to encourage the folks that are with us on the webinar now. Please hang tight after the webinar. I will contact each and every one of you. You will be getting a free consultation with Dr. Bayrak. Thank you for joining us. And are there any further thoughts before we wrap up this afternoon, Dr. Bayrak?
I don't think so. I think we covered these 2 topics pretty extensively. These are very complex and still developing tests, obviously. So, some of these tests that we're talking about today really didn't exist 5 years ago. Some of the latest ones did not exist. Even like some of the basic things that we do now didn't exist 15 years ago. So these are just ever developing tests, and when we talk about the panels next year, it may be totally different. So what I would recommend is, if anybody is interested in hearing more about it, they should just contact our offices, and we'll have a private session with them one-on-one, where we'll be able to explain these new technologies in further detail and whether it applies to them or not. So we'll be happy to talk about these. But I think we did cover quite a bit today. And then at our next seminar, We'll also touch base if there are any additional questions about these two important
Fantastic. I
topics.
also want to encourage everybody to go on our website and join our newsletter. They'll also get updates in regards to the webinars and seminars that are coming up. Thank you, Dr. Byrak, and thank you for the information, and have a wonderful day.
Thank you.